Ladies and gentlemen, I am Dr. Vivekanand Giri, Joint Director, Central TB Division, Ministry of Health, New Delhi. I am a public health specialist by training. So, today we are going to discuss about the services offered by NTEP. So, what are different TB services and how to particularly address the issue pertaining to the TB services. So, TB services as per our NSP is basically divided into three different areas. One is the treatment part, which is most concerned with the drugs and the treatment to the patients. Then the patient centric care, which is basically adherence and the related things. And third, most important, as all of us are aware, one of the target which is there, that is in our NSP also, to reduce the out of pocket expenditure. So, the various interventions by the government to reduce the out of pocket expenditure. So, let us first discuss about the regimen. What are different regimen? Earlier in RNTCP we had the alternate day regimen. So, now right from the implementation of NTEP, we have daily regimen. So, daily regimen is given in terms of FDCs are available in continuation, in intensive phase and continuation phase for the stipulated period depending upon the different category of the patients, and treatment is given as per their body weight. Then next is DST guided treatment. The recent change in the early treatment is mostly the drug sensitivity test, that is the guided treatment. Depending upon the DST results, the drugs which is basically sensitive or drug which is resistant, so accordingly the regimen is changed and patient is put on the that sensitive regimen. The next is shorter regimen. The shorter regimen, there are different evidence based researches, based on the researches, on the recommendation of the NTEGs, and the regimens are been adopted in the program. So, there are different shorter regimens which is basically reducing the duration of the treatment, and this outcome of the patient is improved. Then certain newer drugs are included in the programs like bedaquiline delanoids for the treatment of the drug resistant tuberculosis. So, these are the four different areas on which the program is focusing on the in terms of the treatment part. The next part is about the patient centric care. Here in tuberculosis, adherence of the patient is very crucial. The most common cause usually is the irregular intermittent treatment. So, if patient is not following the regular treatment, or this adherence is not good, so in that situation the outcome of the treatment may not be desirable. So, to improve the adherence, we have the IT enabled adherence support in terms of 99 dots, in terms of mum box, or in terms of particularly visits by the health worker and the treatment provider. So, these are the different modality by which we try to increase the adherence of the patient to the treatment. Then single window delivery of the care. Here the all NTP services are placed in such a way that most of the services will be available in the single window, where the patient need not to visit different health facility for different purpose. Wherever it's possible, most of the things will be at the single health facility. Then comorbidity management. The tuberculosis is a disease where there is a different comorbid conditions are there. In comorbidity play a crucial role for the outcome. Let us say take example of people living with the HIV, then diabetes, then person with the malnutrition. So, these are the comorbidities. So, management of the comorbidity and linkage with the other national programs, like NTP has linkage with the National AIDS Control Program NACP and the data is being shared and the guidelines has been made in due coordination between the different programs, and services are being given in the integrated way to the patients. So, this is the comorbidity management. The next is the tuberculosis is not only the disease, it has certain particularly social determinants also. So, the person, when a patient visiting to the health facility, he will incur certain amounts on the travel, he will incur certain amounts on the treatment, or he will particularly have the loss of wages or certain related thing in which there will be out of pocket expenditure, and government is very keen on the addressing this issue. So, all the treatment and the diagnostic available for tuberculosis either in the private or government or in the privates are the free of cost or at the subsidized rate. Then next is recently in 2018 government has taken a decision for the financial incentive to the patient in terms of direct benefit transfer. DBT, that is the Nikshay Poshan Yojana, in which patient is basically getting the rupees 500 per month till he is under treatment. So, that the rupees 500 will be as a additional nutritional supplement. So, the outcome of the particularly disease will improve, because nutrition play a crucial role in outcome of the disease. Then treatment of the tuberculosis. So, here there after implementation of NTP, earlier in RNTCP drugs was given on the alternate day. Now, the regimen has been on the daily basis. So, drugs are given on the daily basis in the FDCs. Simultaneously, the drugs are given as per the body weight. Then, no need for extension of the intensive phase. As all of us are aware that treatment of the tuberculosis is basically divided into the intensive phase and then the continuation phase. But the recent change in the program is that if smear conversion is not achieved at the end of the intensive phase, that is the 2 month, the DST is done and the regimen is changed accordingly. So, that here with the help of the available NAT services, with the help of CDST, we are identifying the drug resistance early and patient is put appropriately on this particular regimen, so that the issues of the drug resistant tuberculosis will be addressed in a proper way. Then in certain cases, as we know that tuberculosis is a disease which can affect any part of the body except nail and hair. So, sometimes the tuberculosis like CNS tuberculosis, skeletal tuberculosis or disseminated TB. So, continuation phase can be extended by 12 to 24 hours in certain cases. However, based on the clinical decision of this treating physician. So, program has given more of the particularly liberty for the treating physician to take the decisions based on the their clinical expertise. But the extension beyond 12 weeks should be only on the recommendation of expert or the concern in the field. Then sometime it may happen that ADR may be reported. So, to address the adverse drug reactions, the loose drugs would be needed for substitutions in case of ADR with the comorbid conditions. So, program is giving certain loose drugs also based upon the various ADRs to address the ADR issues. Then treatment initiation flow. So, treatment health initiation flow, direct observed treatment. Here the health facility where the diagnosis of the patient is been done, then the patient treatment is available. Then next step is basically community treatment supporter. Community treatment supporter is the person who is basically helping the patient to provide the medicines, to have the particularly supervisions, then to keep the adherence of the patient. So, community treatment supporter, it can be any person, it can be ASHA, it can be a person from his nearby, or it can be any person which is approachable to the patient and who will be ensuring the patient will take the proper treatment. Then family dots. Then as we discussed earlier, there is a ICT based adherence. ICT based adherence, basically 99 dots. 99 dots is a method by which the adherence of the patient, once the patient consume the particular drugs in the FDCs, below the pills there is an toll free number is there. On the toll free number, patient can call so that his adherence will be recorded. Then pill box, then self reporting, SMS reminders, or the pill counting. These are the different method by which the program ensure particular adherence of the patient to the taking the treatment. Then about how this successful treatment outcome is measures. Basically, patient is advised to visit the healthcare facility every month so that the medical officer or the treating physician will ensure the clinical progress, and is there any ADR or is there any further intervention is needed or supplement is needed the treating. So, monthly follow up. Then our field staff in terms of health worker who may be depending upon the different health facility, weekly supervision visit and support by the health worker. So this will enhance the particular treatment outcome. This will enhance the adherence to the patients. Then drug strips handed over to treatment supporter, so that the treatment supporters will basically ensure the regular medicine is consumed by the patients. Then next is a TB treatment card or identity card made prior to the initiation of treatment, so that all related informations pertaining to his diagnosis or his identifications or other things will be made, so that this card will be helpful for the patient. Then treatment to be prescribed by a medical officer. Here in program, the minimum person MBBS doctor is required for particularly diagnosis and the initiation of the treatment, so that the proper treatment protocol will be followed. TB treatment support. So here the TB patient is the heart of our all intervention. So all our interventions are centric toward for the patient. So what are different interventions which basically program is planning? One is the treatment supporter. Treatment supporter basically provide medicines to the patient to ensure the adherence, and their report any ADR or any other intervention is required, and he will help or counsel the patients to maintain the medications. Then counseling. The program, because TB is not only the particular medical disease, it had certain component, the social determinant also, and the stigma attached with the disease also. To address this issue, the counseling is provided for the patients. Then next is about the incentives and enabler. The incentive which are basically provided by the programs, and incentive which is provided by the different various states governments or the different social schemes which are run by the state governments or the government of India. So incentives in the form of Nikshay Poshan Yojana DBT, then incentive for the tribal patient for one time travel expenses reaching to the healthcare facilities, then incentive to the treatments providers, incentive for the private practitioner to notify the disease. Then nutritional supports in terms of this Nikshay Poshan Yojana, then different state governments or districts or different NGOs are working on that, and government of India is basically planning to incorporate a community support for the TB patients, and new scheme is going to launch soon. So nutritional issue, because nutrition play a crucial role, and the outcome of the treatment outcome of the patient depending upon the nutrition. Then pharmacovigilance, because these patient is consuming different drugs, and there will be some sort of adverse event. So pharmacovigilance of the different drugs which is used in program, so that proper intervention can be taken. And then is adherence in terms in ICT adherence in terms of 99 dots, 99 dot lights, or different intervention by which the adherence of the patient can be ensured. So, TB treatment follow-up. TB treatment follow-up is a crucial thing so that during the course of the treatment, patient will be monitored properly and the timely intervention will be planned or early identification of certain things which can be prevented also. So, treatment follow-up basically divided in two parts. One is the clinical and second is the laboratory. So, clinical, as we discussed earlier, the monthly follow-up to the healthcare facility where the treating physician usually examine and check the prognosis of the patient, adherence of the patient depending upon his symptoms, that is subside of symptoms or appearance of new symptoms. Then what is there any adverse drug reactions or any particularly mitigation measures for that ADRs or any preventive steps for further preventing the ADRs. Then weight is one of the important parameters by which basically the prognosis of the patient can be monitored. So, the weight monitoring. Then sometimes it may happen that the patient may have different comorbidity. So, the management of the comorbidity and X-ray test if it is required. This is the clinical particularly follow for the patients. While in case of laboratory, as we aware that laboratory follow up with the help of sputum microscopy, sometimes if it is patient is not properly responding to treatment, then culture and DST, then investigation for ADR and investigation for comorbidity. So, this follow up basically on the clinical as well as the laboratory pattern. So, thank you very much. Thank you for the patience listening.